And what about the patient considerations? Well, what is the pulmonary pathophysiology that you're dealing with? Is it a surfactant deficiency, a compliance problem, an edema problem, of which CPAP is very beneficial for? And if that's the case, then CPAP should be used effectively. If it's an obstructive pattern, then CPAP by itself often is not very good, and particularly if the CO2s are very high, you need additional support. From a cardiac standpoint, if you're having cardiac output problems, one must be very careful with the amount of CPAP used because it will over-distend the lung and decrease venous return, which then obviously decreases cardiac output. So you have to look at how the heart's working to make a decision on how are we going to utilize the CPAP most effectively. From a central nervous system standpoint, again, if you're impeding venous return, you are impeding blood flow to the brain. If you over-distend the lung, you impede venous return from the brain, which can increase intracranial hemorrhage. So again, for a small preterm infant, you want to be careful that you keep the lung in a uniform inflation and not over or under inflated. From the GI standpoint, babies who have abdominal distension because of an ileus, CPAP is probably not recommended because you may have them put more and more gas into their stomach, and because it's not moving through the intestinal tract, their abdomen becomes more and more distended, which pushes up on their diaphragm, alters their lung compliance, and makes it very difficult for them to breathe. So again, for a baby who's got a predominant GI problem, then CPAP is probably not a good choice for them. Well, now we move on to what's been done more recently, which is CPAP with assisted ventilation. You can use conventional breaths. And why would you do that? Well, the answer is if the CO2 is staying high and the baby's not breathing as deeply as you'd like, giving a positive breath through the nose causes them reflexly to take a breath, and it may help them ventilate better. How much do you use? I think most people would use a background rate up to about 20 to 25 and a peak pressure of around 20 to 25. Again, positioning of the CPAP makes a difference because if the baby moves, that pressure won't be delivered, and if the baby's prongs are in very tightly, then the full pressure gets delivered. So one has to be careful when you put a conventional breath into the system. Well, what about using it with high-frequency pulsations? We've done some work in the Lamb lab, and that proves to be very effective with that. The high-frequency pulsations may assist in ventilating better and not providing bigger tidal volumes, so being less injurious. And again, those can be applied through nasal prongs, or those can be applied through an ET tube with that, and can be very effective from that standpoint. I've used the high-frequency oscillator to give CPAP when I thought the patient might fail coming off of the oscillator, and that's also proven to be very effective. But from a high-frequency standpoint, some studies that are ongoing need to be completed to know how well it will work, and how much is the same end expiratory pressure you'd normally use, and then the amplitude around that is adjusted to adequately ventilate the patient. The next, even more recent thing that we've done is a high-flow nasal cannula. Those are delivered through a heated, humidified gas. The reason that people like them is because it's more user-friendly to the baby. The cannulas fit in easier, and the nurse doesn't have to worry about keeping it tightly in the nose, and it can be less irritating to the baby with that. Flows are typically used between 2 and 6 liters, and they can be very effective. What are the risks? The risks are that we have no idea how much pressure is actually being delivered to the patient. I've done some personal measurements with a pressure-tipped catheter, And what that's demonstrated is that you can have on 6 liters a end expiratory pressure of 4 or an end expiratory pressure of 10. Depends on the size of the cannula, how tightly it fits, and whether the baby opens the mouth or not. So the risk is you could, by using it, over-distend the patient just as you could with CPAP and cause problems from that standpoint. The benefits are that it is, from a nurse standpoint, easier to do, and from a baby standpoint, it's less irritative, and so the baby may need less sedation and may therefore breathe more deeply and vigorously on their own, and may then support that system. So I think in summary, non-invasive ventilation is here to stay. We all know that getting a baby off a ventilator is very important, and the faster you can do that is even more important. And so utilizing CPAP with a rate, utilizing what one would call non-invasive mechanical ventilation, and using a high-flow nasal cannula, and possibly CPAP with high-frequency pulsations, all may prove to be very effective and minimize the time that many of these babies need on the ventilator, which we know will reduce the risk and incidence of chronic lung disease. Thank you.